I will hand it over to Professor Sandhya Kaushika from TIFR, Mumbai, who will be moderating the session.
Welcome everybody to this WebGyan. COVID-GYAN is an effort which is a multi-institutional effort to provide scientifically accurate information to the discerning reader in an understandable manner. And in addition, we want to convert all of that information, the scientific information, into different Indian languages such that people can access accurate information and make good personal choices or just be informed about the pandemic and its spread. One effort under COVID-GYAN, which is the effort from the TIFR, the institutes under TIFR, Tata Memorial Center, as well as IISc, is WebGyan, the series where we get different speakers who work on different facets of COVID or are well informed about the pandemic as it has been occurring in India and elsewhere, to share their perspective and in some cases, their research with the lay audience. In this series, today we have Dr. Giridhara Babu, who is, there's only one word to describe him. He's a doctor with great deal of interest in public health. And after his MBBS, he worked in AIIMS as a resident, and then with WHO for several years. He worked in Karnataka, working with basically infectious diseases. He has also been involved. Later on, he went to the US and got a master's in public health as well as a PhD, and set up in his own work that he does in Public Health Foundation of India. He has done work with non-communicable diseases and more recently with COVID. So I give you Giridhara Babu.
Thank you. Good evening, everyone. I am here to present my experience with evidence-based implementation of COVID-19 public health measures in India with specific focus on the Karnataka state. So this is how evidence-based public health can be generally defined as. It's the process of integrating science-based interventions where people are actively participating. We know that the community preferences are taken care, and with that, the overall objective is to improve the health of the population. So that's what evidence-based public health practice is. But to understand public health, we need to understand that it is not just the individual's health, like your health, my health, but also the healthy societies. And to have healthy societies or communities or countries, there are several determinants of health, both proximal and distal. So during COVID-19 response, we have seen how these determinants of health affect the overall response. So at the individual level, we have seen elderly and those with the comorbidities are affected more, and therefore they need additional prioritization. In terms of individual lifestyle factors, we saw that the obese conditions, any clinical outcome was adverse when it comes to people with overweight and obesity. Beyond that, what kind of social support system that we had, whether we are employed or not, are we allowed to work from home or not, what kind of facilities are there, all these determines whether one is healthy, communities are healthy or not. So when we want evidence, we need evidence for all these domains of determinants of health, not just some aspect of it. So that's the holistic perspective of understanding what all the information required in terms of assessing healthy communities. In my role as an epidemiologist, epidemiology, as you know, has been in the news, at least during COVID-19 time, uh, for both good and not so good reasons. But this is what we generally do. And I have tried to summarize the role of epidemiology in the overall implementation of evidence-based public health. So as an epidemiologist, we contribute to generate data or information, and that we do through several study designs and also through several concepts in epidemiology related to data collection, data analysis. All those things are almost 90% of the work that any epidemiologist does. The next step in the implementation of evidence-based public health is, once you have the data, how are you analyzing it? How do you make inferences out of that? And there are concepts in epidemiology which will help in terms of bias analysis and causal inference. Then is the most important step, which is the action. So once you have the data and the inference, what are the actions that you take? Even there, epidemiology has tools to monitor, evaluate, and support the ongoing implementation. So I'm going to broadly cover these concepts in today's talk. What kind of data we have, where is it, and then how do you interpret the data related to COVID-19? How do you use the data that you already have, and other correlates are for discussion towards the end. This is the basic structure of how the data gets collected in India. So DSU is District Surveillance Unit, SSU is State Surveillance Unit, and CSU is central. Now, the data gets collected at the district level, then it goes to the state, and then it goes to the national headquarters. The national headquarters for all the data that gets generated in disease surveillance program, the national headquarters is NCDC, National Centers for Disease Control. This is the CDC equivalent in India. Now, therefore, the district is the primary unit of collection of data. And where do they get data from? They get data from both public and private health sector. And in the public sector, you'll see a wide range of units: primary health centers, community health centers, district hospitals, taluk, medical colleges. In the private sector, you have isolated nursing homes, corporate hospitals, then you have private practitioners. Once the data gets collated, the ambition of the program was that the data gets used at the district level for action. That's how we define surveillance. Surveillance is systematic collection of data for action at the local level, but that's probably not happening everywhere, as one would expect to see. At least at the state level, then we should have capacity to collate the data of high quality, analyze it, and use it locally. And whichever state does that well, they'll be able to control the outbreaks much earlier. If the central surveillance unit at the NCDC has to intervene, and they should go around the entire country detecting outbreaks and responding to it, that means that the district and state level are not very efficient. So that's the overall architecture. But then if you want to collect the data, just for COVID-19, I'm explaining this. Let's start with the data that comes from every COVID-19 positive person. The laboratory data, whether positive, negative, and it correlates, they go to ICMR. And the clinical data in terms of whether it's mild or moderate, what is the prognosis, what's the advice at the discharge, all that goes to National Centers for Disease Control. Then you have state governments which have the district level data in terms of testing, all the other details in terms of infrastructure within the districts. Then there are studies which will independently give the information. In addition to all this, there are many agencies which work with the Ministry of Health and Family Welfare, where they provide the data through their own collection processes. In addition to this entire machinery of health ministry, you have Niti Aayog, which has been very active in COVID-19 response in terms of managing logistics, vaccines, and partners, and other areas. But the hallmark of this response has been the involvement of Home Ministry, invoking Disaster Management Act and Epidemic Disease Control Act, and getting most of the regulations within their purview. So now, if you need something as simple as test per million, I need to get district data from the state government. Then if I want to collate at the state level and correlate with the lab data, I need to go to the ICMR. Then to know whether that person is discharged or not, recovered or not, I need to get to NCDC. So just at one individual level, something as simple as test per million, if I have to represent accurately, then these are the different agencies one needs to collect data from. If that itself is complicated, even within health department, what you see as clouds are not really clouds, but meant to be depictions of the kind of data element somewhere in the cloud. And how do you then converge onto a single platform? So what you see here is there are vertical programs for most of these which are represented here. Leprosy program has its own set of data. RNTCP is for tuberculosis control. Now that has its own sets of data, and they have some of the phenomenal apps and the way they made it mandatory to report tuberculosis. So there's that. Then there is nutritional surveillance data, National AIDS Control Program and its data. The polio surveillance program has its data from acute flaccid paralysis and measles and others. You have NPCB for blindness. And all of these are vertical programs without any integration, either at the state level or at the central level. The point of collection is same, which is at the most, in the remote areas or anywhere you go in India, a junior health assistant female or ASHA, who is another extension of the JHA, but as a volunteer, she helps in several bits of data being collected. The entry level is same for all these programs, but as it goes up, it goes into different vertical silos which do not actually speak to each other. So therefore, although this quote is misattributed to Bismarck and there are controversies who said it, but whoever said it really well. Whether it is a law or a policy, the act of making it, how it gets implemented is the most complicated. And I use this as a intro remark for how the entire data gets used. And I will try to explain in terms of COVID-19 response so far. Now, this is what we call as epidemic intelligence. Let's forget there is no COVID-19 and it's over now with whatever act of some mystery in the next few weeks. Next time around, if there is any outbreak which might turn into pandemic or even epidemic, then how do we detect? So in India, the integrated disease surveillance program has two components, which is indicator based and event based, and both have indicator based is where active involvement is there, whereas the event based is through the media and all the other information sources. But the point here is to make sure that the state or the district proactively detects area where likely there is an outbreak. They send out some rapid response team, and there it will be controlled. Imagine if things could have been controlled in Wuhan very early on, if an epidemic intelligence unit was very active and all the regulations were followed, then maybe it is wishful to think there would not have been a pandemic. So this is the strength of having strong surveillance and the systems talking to each other. If the system is proactive, we should be able to prevent the spread of the infectious disease. But the moment we want to talk about the data, now my data will be different from your data, mainly because our own perspectives. What are we looking at in terms of the data element that I attach importance to? And in this endeavor, people miss the elephant and hang on to the tail or the trunk without actually understanding what's going on. I'll give you examples on why it is so. But as much as from which is the data that we are speaking, what kind of data that are we speaking is also important. So this is hierarchy of quality of evidence. On top of it is systematic reviews of randomized controlled trials. Then you have a randomized controlled trial. Just to give an example, Lancet had a publication where a randomized controlled trial results were published about AstraZeneca vaccine. And if you would see the confidence limits, WHO has prescribed a safety limit of 30% vaccine efficacy, but at least in some of the groups, it is less than 30%. So now I know that what is the use of this evidence by looking at the randomized controlled trial, assuming all the other sources of error are controlled. Next in the hierarchy is cohort studies, non-randomized trials, and other types of new variants of case control studies, then case control, cross-sectional. Then you have case reports in non-peer reviewed journals, opinions, and finally you have press releases, blogs, social media. I should have added WhatsApp forwards and Facebook messages and whatnot. Now, social media is there, but if most of the decisions are made based on the lowest in the hierarchy of the quality of the data, and then that's a problem. So if I'm making a decision based on opinion of a celebrity doctor or a celebrity person, then probably that's completely biased. On the other hand, do we have systematic reviews or randomized controlled trial for everything that we want to implement? That's also is not possible. So you have to make a choice in terms of what kind of quality of data that you have. And based on that, you make some decisions on implementation. And one such element of information is Global Health Security Index. And now this is done by the John Hopkins group, and there are it is widely known and well reputed. What it does is it has a set of 140 questions that will assess what kind of prevention efforts are there, what are the detection and reporting efforts, how rapidly they'll be able to respond, what is the health system preparedness, and whether they follow international health regulations or not, and what's the overall risk environment. So if you assess all these, this is how it looks like. All that you see in yellow are the most prepared. I'll come to which countries are those in the next slide. Then we have orangish countries where we know that they are moderately prepared and probably have a lot of problems if there is any pandemic. The least prepared countries marked in red are the ones which we need to watch out for. So India's rank is 57 and its index is 46.5. Now I'm not presenting this to make a case why India is better than other countries, but this is the most comprehensive, objective indicator one can have in terms of understanding preparedness for a pandemic and its response. And yet, this is the publication from PLOS ONE where they show this is the ranking of the countries based on the Global Health Security Index. And you would see United States, I'm really sorry for the quality of the slide here, but then this is how the +1 would allow us to show. So United States is ranked 1, United Kingdom is ranked in the 2nd position, followed by Netherlands, Australia, Canada, Sweden, Denmark, South Korea, so on and so forth. Which means that in each of these domains, which I mentioned in the previous slide, these countries have done really well. Therefore, they're ranked, we should have United States as the leader in terms of responding to COVID-19 pandemic, followed by UK. Is that the case? Probably not. And the authors did a wonderful job in assessing how the response of these countries, the OECD countries, was in terms of the COVID-19 response, and they picked their indicators in terms of how to assess. The first one was what is the burden of cases. So if cases per million are lower, then the rank is better. Deaths per million was another one, where fewer deaths is better ranked. Then you had recovery rate, then you have test per 1,000, which can be test per million. The unit is of your choice, but if you have these, then the ranking changes completely, and you would see that New Zealand is ranked 1, followed by Australia, then South Korea, then other countries which were not there in the top 10 countries, Lithuania, Slovakia, Latvia, Ireland, Israel. So what's happening here? What's happening is this: the countries that have ranked really high on Global Health Security Index, they have a moderate to poor response when it comes to COVID-19. And there are, it's not a regular pattern that you can observe, but you look at countries such as Israel, which is not very well ranked in terms of global health security, but they've done tremendously well in responding to COVID-19. Same thing with New Zealand and other countries which are not so ranked. So what is the point here? The point is that any objective indicators that assess preparedness and response probably are missing some of the important elements when it comes to pandemic management, which I hypothesize that the kind of innovation that are put in place, the kind of teamwork done, collaborations done, the role of quick turnaround time for science and technology, especially in ramping up the diagnostics and treatment and leadership. So if you were to then assess these and probably combine with this, maybe an index would be different. So we have data, but can we use the data to predict or ensure that preparedness and response is good? Probably not. So this needs revision again. And as you see, as of now, United States is going through major problems in terms of daily number of deaths. UK, they started vaccination, but we'll have to see how they will be able to control with that. The next step I would want to explain is on, you have the data from wherever you got it, how do you then interpret? So, and this is one of my most repeated slides in most of the presentations. The reason is simple. Across all the public health programs I have worked in India, this problem, this fallacy is a common one. And that's why it is important to stress again and again, which is this. Now, the narrative in many of the discussions you see is that most of the cases are coming from 5 or 6 states, and these are Maharashtra, Karnataka, Andhra Pradesh, Tamil Nadu. Now, although the narrative is not with the intention of probably putting these states in spot, but that's what generally happens in the perception of whoever listens to this. Now, the states, I have shown these different shades. Now let's start with the first one. This is state-wise distribution of tests per million. And the darker the green shade is, the higher is the test per million. The next map shows cases per million, where the darker shade shows that there are more cases per million. Then you have deaths per million. So what is more than correlation you would see here is the states that do higher tests per million are the ones which have higher cases per million. And they're also the states which are reporting higher deaths. Does that mean that there are many areas in the central belt and the northern belt which probably have higher population density than these 4 or 5 states? Do they have some kind of immunity uh, by some act of enigmatic or miracle or magic, that people there don't get infected or they don't get the same severity as the people in Maharashtra or Andhra Pradesh or Tamil Nadu would go through? The answer nobody will give, but the narratives don't change. The same thing has happened in the AIDS control program, same thing with the measles, same thing with the polio surveillance. This story gets repeated in every disease control program. What's really happening is the states that have better surveillance system, the states that have built the capacity of public health workforce at different levels are the ones which will report cases well and deaths well. That doesn't mean that they are the problem states. Problem states are those states where we are missing the areas of transmission. From an equity point of view, a poor man, a migrant, or an elderly living in the states where the detection is poor are probably going to develop complications or even die because the efforts have not been there up to the mark. So therefore, the narrative has to change, even in the public perception, that higher number of cases is not to be stigmatized, but it's actually the opposite of that, where poor reporting should be given more focus for review. And this is an important way of how even the descriptive data that we have gets reported. And this is another most important aspect. And if you see this, this is the distribution of influenza-like illness and severe acute respiratory infections from November 19 to March 2020. And you would see that in Jan, Feb, and March, there is an increase. But whether it is expected or is it more than expected, we need to look into that. At the same time, if you want to look into the states which report like this, Karnataka reported total number of cases between January to March much higher than neighboring Tamil Nadu state or Maharashtra or Andhra Pradesh. So when you have something like this, should we say Karnataka has higher problem because they have more ILIs? It so happens that Karnataka implemented the WHO's and NCDC's program of strengthening the overall surveillance systems and the dashboard that the WHO wanted to develop. Therefore, Karnataka state started reporting all the ILI cases much better than the other states. So we don't have the same data from all the states. And then this paper came, which is very important in my sense. This paper did not get enough credit that it should have got. This is published in the month of April by Indian Council of Medical Research and their authors. What they did was they tested severe acute respiratory infection cases all over the country, and they wanted to estimate whether COVID-19 positivity can be then seen at the level of districts. And their findings were very important. They said, and this is direct quote from the paper, 52 districts in 20 states have COVID-19 positivity. This is very early in the outbreak. And if you look at the states that and the number of districts which had COVID-19 positivity, you would know where the high burden was. This was not acted upon by many people. I mean, I wouldn't even for a second get deviated into the controversies. This is pure science. Here was a high quality paper which looked at SARI cases. They tested their blood and they found who is positive and not. And they said it's already present in many districts which are not actually reporting COVID-19 otherwise. So we need to act on this. The actions taken based on this data and what happened afterwards, it's in the public domain, but as an epidemiologist, as a public health practitioner, it was a moment of huge disappointment that there's such beautiful data there. Why are we not acting on it? Why can't these districts be reviewed strongly? Why can't the response be stepped up in these districts? Maybe things could have been different if those actions were taken in those districts. And when you see how many cases of influenza-like illness one can expect in these states, it's purely again a matter of reporting. If the state reported well earlier, then their expected numbers is also higher. So therefore, there's no baseline. As a country, we do not yet figured out what will be the baseline expected rate for ILI or SARI. And that will happen only when you have high quality data. So therefore, strengthening data collection systems and integrating these platforms is very, very important. The next set of slides, in terms of the pre-authorizations raised for ILI and SARI during November 19 to April 2020. And because of reporting, few states do much higher compared to the other states, and there's no data available for some other states. The next set of data that we have is from sero surveys. And the ICMR sero survey showed that in the first round, case to infection ratio is around 100, which means for every reported case, there are around 100 infections we might have undetected or missed. This dropped to 26 by the second round. And as the paper clearly explains, it's probably because enhanced testing and using better testing strategy and more awareness and revised testing criteria and all that. But the utility of case to infection ratio to strengthen the overall public health response has not been up to the mark. And again, it has not got the deserving attention as an indicator one should have acted upon. So to correct that, we did a survey in Karnataka state, and this is under review for publication, both in a preprint server and on a peer-reviewed journal. I'll be presenting some of it, which is already in the public domain. I will, if you have got any specific questions, I can answer later, but then the data is only pertaining to what is already available. So the objective was to understand the overall prevalence of COVID-19 in the general population. And we wanted to know not just those who had infection in the past, we also wanted to know who have currently, that is active infection. So when we set out to do this, this is an effort of not one person or one institute. This is a phenomenal effort. I have acknowledgement slides to show the kind of efforts that we have put in, but this is a mammoth exercise of being in the entire state and having as much representative sample one can have. So we had three categories. The low risk comprised of pregnant women and those who come to the outpatient clinics. We had moderate risk, which comprised of several risk groups, such as those engaged in high contact with the general population, such as bus conductors, vegetable market vendors, health workers, people in the containment zones, those who work in congregate settings such as markets, malls, retail stores, bus stops. Then we had high risk, which comprised of people in the elderly and those with comorbid conditions. And this is the split of sample size for every risk group, making it 432 in every unit which we studied. And what do we mean by unit? We did this study spread across 290 facilities in the 30 districts of Karnataka. And in Bangalore, we had 8 zones, and each zone was taken as 1 unit. So therefore, there are 38 units, and the sample, each unit had the number of samples, 432 samples collected from those units. And in terms of data collection, this is most wonderfully done by Shiva Atreya of Indian Statistical Institute and Rajesh from the Indian Institute of Science, in terms of how to strengthen the public health response in the state by integrating the data from the survey app and from the ICMR app into one unified data collection platform. And then to get the line list cleaned, and to clean the line list, we had immense help from the Department of Health, Family Welfare, and the team members of the investigators. This is what it looked like. We collected information from 16,913 people. In the end, we had 15,957 who were considered for analysis in terms of IgG. Similarly, for RT-PCR, we had 13,340, and rapid antigen test, we had 8,673. And this is what we found. We found a prevalence of 16.4% of the people having IgG against SARS-CoV-2. In the past, they must have had an infection. That's why we could detect. And we can't really explain in terms of the time frame when they might have had the infection. The next set of indicators was in terms of active infection. So in active infection, we found that there are 12.7% of the population has active infection, making it a total prevalence of 27.3. So nearly more than 1 in 4, either currently infected or infected in the past. That's what we found from this survey. And we have distribution for age, gender, and the risk categories. And in the risk categories, we show that the prevalence is highest in the high risk, followed by moderate risk, and then the low risk, which shows that the representativeness of these risk groups is really robust. And then this is the distribution of IgG prevalence, with some of the zones in Bangalore, like West, South, East, having 35, 30, and 25, followed by other districts, whereas entire Karnataka is shown in the orange. And you had districts like Bagalkot, Gadag, and Chikballapur, which had very low seroprevalence, indicating that the districts are yet to see the surge in cases. And if you overlay the information on percentage of acute infection in these districts, Ballari, Davangere, Tumkur, and Udupi were actually having higher proportion of acute active cases during the time that we did the survey. So therefore, what we found, and then we expressed in terms of the reason I was asked to present these results from the statewide survey, but the context here is case to infection ratio. Now, if you were to plot the case to infection ratio and the COVID-19 overall prevalence, you will see that there is one group of districts on the left upper quadrant where the case to infection ratio is high, which means for every reported case, there are more number of missed cases. At the same time, the COVID-19 prevalence is low there, which means that the proportion of people who are infected in the past are fewer. So therefore, they are yet to search and they are probably not testing well. So you need to increase the testing there. Then you go to the next quadrant where the prevalence is high, but the case to infection ratio is also high, which means despite of having high case to infection, despite of having higher proportion of people who are infected in the past, because of poor testing strategy, we might have missed more cases than what it appears. So this is phenomenally useful information in terms of how do you take action. Same thing for comparing with test positivity rate and case to infection ratio. So then we found out which districts have poor indicators and we plotted them. And this is a Venn diagram to show what did we list from the survey. And on one side, you have the Government of India informing the state government which districts need strengthening. So Bellary and Belgaum were common to both recommendations, whereas the districts with problems that we listed out, we had 5, whereas the Government of India report gave a list of other few districts. Even within Bangalore, if you see how it is distributed, the central zones have probably higher proportion compared to the peripheral or the erstwhile city municipal corporations, which are yet to surge at that point of time, but now we'll have to see what will happen in the second round in these units. Despite of all of our work, the number of days from sample collection to data entry in the ICMR portal was like this. So this is another area where the data collection can be improved. So based on this survey, what we have done is probably this is the first such survey done in the country. And we haven't, although it's very ambitious to say that nowhere else people have done, but we don't, except for a protocol, we have not found a study which reports both acute and past evidence of infection in the same population in a representative sample. So that's what this survey has done. So full credit to the state government for getting this done and for getting all the institutes on board and using this evidence for changing. So all that I said in the earlier part of the presentation was to say where the data is, what kind of quality it is. And here is an effort where the state government has not only sponsored a study, but got the best of the institutes to collaborate so that they can use these results for action. So we definitely feel that this is a privilege that you work in an ecosystem with a state government which is forward-looking and using evidence for change in public health policy. So without their efforts, this survey would not have been complete. So as scientists, we all have our wish list, but the mammoth work in the field of doing the 290 plus facilities, collecting it, sending it to the lab, throughout the state, ensuring that the data entry is made. This is only possible because the state government officials from the most remote areas till the head of the department, everybody got involved in this. So we are highly grateful to the entire health and family welfare department. In addition to that, there are many people who have helped in getting this data collected, cleaned, analyzed, and then be able to show the results the way we are showing. We have submitted to a journal which is under review. There is a med file which is under screening, and the moment it is there, it will be shared in public for public discussion. at this, okay, I have taken 45 minutes and I conclude here, and I'm very happy to answer any questions you might have. Thank you.
Thank you, Dr. Babu. That was a really comprehensive talk and very interesting. And exactly what I expected from you, actually, because I've heard you in a couple of other fora in panel discussions. We are now open for questions. Anybody can put their questions in the chat box. And I have a couple myself, and I thought I would start off with those. What you described in the beginning was actually, it seems that there was very little coordination between the multiple agencies. It was not clear what was under state and what was under the central government. And I have often heard that, health is a state subject, yet the data seems to be collected for national efforts. So how do you envisage as a public health worker that this, what appears to be a long-standing problem with independent efforts for polio and leprosy and TB and now COVID, to actually achieve the necessary integration and coordination between agencies and between the state and the center?
I think this is probably the wish on every public health practitioner's mind. I have often heard Professor Ravi of NIMHANS saying that if you can see integration of all the surveillance platform happen now, at least because of the COVID-19 response, that is the greatest thing one could have witnessed in the entire lifetime. So I completely believe that statement. The reason is not by design, but by the way the programs get funded, the way the collaborations are set in. There are different programs requiring different data requirements. So if I'm a funder, I'll say, no, I don't want probably to have the data in multiple platforms. I just want it in this way. I want dedicated line of workers for this. So that's in the interest. But no funder will say no, including the multinational NGOs or WHO. If the government says no, we are not going to run another vertical program. So this debate of many vertical programs versus integration has been going on for long. But what we suggest is, if the data collection platform is same, if the worker is the same person, why not simplify and have minimum set of parameters? And my own engagement with the experts, not just within public health, with whom we generally interact, but outside public health, physicists, biologists, mathematicians, modelers, when you look at the kind of inputs they bring in, I am very much encouraged that the solutions are there out within the country, within the same ecosystem. It is just for the sustenance of the kind of these new collaborations that are built to be carried in future in integrating data entry platforms, so that the data that gets fed into the state and national level are used appropriately. So there are multiple users, but the person who collects the data is same. I think it is possible if at the highest level the decisions are made in terms of changing the scenario.
Thank you. Here's a question from Pragnya Santra. Can herd immunity result in diminishing the COVID cases, or will it result in rapid curing of the infected individuals? Although this is not quite, perhaps, but perhaps you can at least let us know, what is it now that, the vaccine is close by, hopefully, at least for some sector of people in a few months. And we have a fairly high, and it seems surging infection rate in places. What do you think is going to be the state in the population?
Okay, so let me explain what herd immunity and how it will have an impact on the COVID burden. Uh, to begin with, Mumbai had higher proportion of cases reporting, and when we got the sero survey results there, we saw that the seroprevalence is increasing, and with increased seroprevalence, we also saw that there is a drop in cases after a point of time. So the number of cases will come down when the susceptible pool start getting diminished. So a susceptible pool is a pool of all persons who are yet to be infected. And the more the number of people, higher will be the cases. As you reach nearer to the herd immunity, the number of people who can be infected are fewer, and therefore the cases will drop. And in terms of your the next part of the question, where since vaccines are around the corner, and even if that means around the corner means a year or 6 months, we don't know when, but when they're available, what is the overall response going to be? And that's a very difficult question to answer for countries that have seen higher burden of disease in the past, because few questions which have remained unanswered. If somebody is already infected in the past, would they still require a vaccine? And if yes, what is the added benefit or risk? And so far, no trial has actually done studies in those who are already infected. The next set of questions are in terms of prioritizing. Already the prioritization is made for the elderly, those with comorbidities, and healthcare workers, other frontline workers. What about children? Should we vaccinate them or not? Are they part of the trials for these vaccines? And since they are not, what are our plans of including them in trials, and then the actions that follow afterwards? So I believe the expert group constituted by the government will answer all these questions, and there is a comprehensive vaccine policy as such. But I'm optimistic that if a safe and effective vaccine is available in India, we can roll out because we have proven systems for vaccine distribution.
There's another question here from Professor Rudra Pratap.
I saw that.
You saw that. But anyway, that's a question that is going to come up because, there was this study reported with very high prevalence, especially in rural districts, and your data sort of does not quite, the numbers are not quite there yet in the same range anyway.
Yeah. So this study, which is also in the preprint now, which we actually saw when we were submitting. This was done a month before. But in terms of representativeness, we have covered every district. We have covered more number of units in Bangalore. And then we have covered more number of risk groups. So I should have added most comprehensive when I to qualify what I said. And whenever you say the first study, there are going to be many questions asked. I'm happy Dr. Rudra Pratap asked. And we can discuss after this session is over in terms of what is the uniqueness of our study and the other study.
But compared to, so there's this other question where they were talking, where Rajan Karna talks about Dharavi and how Dharavi has been held up as a, in terms of COVID management, that can it be said that, Dharavi has achieved herd immunity? I think that's difficult to address, but at least it appeared that the management systems in Dharavi to control the epidemic were much talked about and how effective it was. Do you have any thoughts on that?
No, I would, to agree with Dr. Rajan, I'll have to understand the proportion of antibodies in the population there to say whether they've achieved herd immunity. But as a matter of conjecture, or in terms of assessing if there are no more cases coming from there, if everybody there seems to be not getting infected even when the transmission is going on in other areas. This can be one of the potential answers.
Can I ask a question?
Yes, go ahead, Uma.
Hi, yeah. Hi, Giri. Thanks. That was a great talk. I was wondering, this not to demonize or vilify states, but the reason for poor performance in states like Bellary, Bidar, etc., which you pointed out, that very nice quadrant analysis. I thought that was really interesting. Is it because there are fewer nodes, that there are fewer people who are actually like healthcare, like public health workers who are participating in this surveillance system? Or is it because there's poorer connection between those or communication and transmission of information and action? Can we break it down even further? Or is it that, you showed that graph where sometimes reporting of test results to ICMR was taking longer? So was it because there was a higher time to testing reporting in those places? So is it initially, or is it like, getting the results, or, the actual testing, the getting the results, or acting upon the results? What do you think was the weak link here?
I think it's a combination of several factors. Generally, I mean, if you see the way public health programs get implemented, reviewed, and improved, the nearer you are to the state capital, better is the overall performance of the public health program. The further away you go, any state for that matter, there is these huge disparities within the state and within the districts in terms of performance due to several reasons which you have explained well. I'm afraid we do not have the whole range of data to go further. We still can do some analysis in terms of where which functional element was the problem, but you can only get to probably these process indicators, but you can't go to earlier antecedents of this in terms of whether health worker density and their communication, all these things we have not collected as variables in the study. So therefore we can't further delineate, but we have other sources of information. And when you review the district at the district level, you have other contextual factors such as the district magistrate would know what is the health worker density there, what kind of communication is there, and compared to the guidelines by the government, what kind of inference he can draw from implementation. Can he or she send their own monitors to see how the program is done? The district health officer is the leader in the district for implementation. They would know a lot of contextual factors. I think once you own the data, you say, okay, this is the program, this is my data. Now let me use this data to implement some actions. Then you naturally use all these contextual inputs to strengthen the implementation. I see another question.
Yeah, I think that would be really useful, because I mean, going ahead, what can we do, right? That would be a good thing to think about.
So there's another question about the sero survey, especially that you did, which is, if you can see from Deepak Subramani, when you do the sero surveys, how did you randomly sample, and what data models were used to project the sample statistics to population statistics?
So what we did was systematic random sampling, and we will share the entire study once it gets published in the Med Archive. But to answer the question on how to make then approximation to the population level, we have used a design effect which we use generally for cluster sampling, which means that we have accounted for that as well. We have also done weighting for the population and also adjusted for sensitivity and specificity of the test. So in terms of making it accurate in terms of statistical methodologies, we have followed that. And it's up to the reviewers now to assess and then say how good it is, but then we have done whatever is possible to do. Can I also answer Shashi Kumar Ganeshan's question?
Yes, definitely. I was thinking perhaps since we're still looking at the Zero Survey question, could we take this question from YouTube from Srinivasan Venkatraman? In the plot that compared case to infection ratio and test positivity, there seems to be a negative relationship. Isn't that counterintuitive? And he goes on to say his understanding is that more the chance that the community infections are missed.
Yeah, this is a very good question. So what we did was we were looking at, see, test positivity is a dynamic thing. It will be higher during the surge in cases. It will be lower either in the place where surge is yet to happen or the surge has already been complete. So therefore, it depends on which state the district is in as the surge already passed or not. Whereas the case to infection ratio is looking at a cumulative number of cases and cumulative infection. So yes, it is a bit counterintuitive, but the moment you put other things in context and analyze whether the surge has already occurred or not, what is the testing numbers, then we can explain. So it can't, one of the important things from all these data outputs we did was, we did not use one single indicator to say this district needs to improve, let's say, testing. But we developed comprehensive set of inputs to say that, okay, in this district, probably case to infection ratio is higher. The infection fatality rate is also higher. We saw also that the test positivity is higher. So therefore, the inferences are A, B, C, and therefore the actions that you need to do are X, Y, Z. So this is how we as investigators have given specific action points for each district, which the state administration has immediately acted upon and then shared it with the districts.
So Shashi Kumar Ganeshan had
So his question is what?
This question, which I think Dr. Babu wants. What magic number brought down the number of new COVID infections in India even before the vaccine? In that context, I'd also like to even before the vaccine. In that context, I'll also like, which said that 52 districts where they did the SARI survey, looking at that early data, and if you modeled from there, or you sort of look at the current status, can you sort of say that where we are today is because of that very early? This is sort of similar to the other question, which is about quarantine enforcement early on was perhaps.
So the first question, in terms of magic, both Dr. Ganeshan and myself, none of us believe in magic, but the herd immunity as a concept, if you have to compare one area to another, there has been transmission going on from one area to another temporarily, also from one point of time to another point of time. So I would actually look at it from a completely different perspective. During lockdown, the states that did not implement the lockdown well are the ones which had earlier transmission, widespread transmission going on. And at that time, the regulations were followed in some states where the outbreak was not allowed to establish. After that, when the unlock began, there has been free movement and bound to get increased transmission everywhere else. So whether it was a wildfire out there or whether it was a controlled spread, it all depended on the compliance of public health measures, use of masks, improved testing, several factors. But the net result is that different areas are reaching the thresholds for population immunity at different points of time. So when the high density gets affected first, you'll have more number of cases. And as you spread out to rural areas and other cities, the number of cases will go down, but that doesn't mean that the virus has disappeared or there's no circulation going on. So the numbers have come down for sure, yes, but they'll not disappear. And I will say this is a low level of play too for some time. And when the vaccine comes, probably then again the dipping will continue. The other question, I'm sorry, either my connectivity is poor. I could not really listen to the next question. Can you please repeat? What was the other question?
The other question was about quarantine enforcement, and given that, I mean, I sort of weaved it into the fact that you pointed out the ICMR early SARI cases, which suggested there was a lot of spread already, and how much of where we are today is because of that very initial spread, which was perhaps even before lockdown had occurred, and how much of it do you think could be due to quarantine? And
Yeah, I have actually not
is it
seen.
even possible to take an intelligent guess about it?
Yeah, a great question, but I would actually ask some of the modelers to work on these scenarios where if it would, if these measures were taken early on, what could have been the difference? What is the quantum of cases or deaths that could have been mitigated because of those measures? But that's only an assumption, and we really don't know. My own educated guess is that the districts which the ICMR papers talks about are not like Mumbai or Delhi or Bangalore. So generally the district headquarter will have probably higher population density, and the other block or taluk level may not have that kind of high population density. Therefore, the outbreaks would have played out there, probably reaching thresholds for population immunity, at least in some pockets. And therefore, after the testing actually got increased, maybe they got integrated into the overall response. So we may not have missed a colossal number of cases, but that doesn't mean that we have not missed. So to quantify by what factor, we need to do further studies.
On that note of having missed, and all your early part of the talk, we talked about data reporting structures. Any estimate of how many deaths we have missed? Because there is a prevalent notion in the general public, especially forwarded through WhatsApp, that Indians are just special in some way, or our immune systems are special, or our exposure is special, and our deaths are very low. And given the fragility of our data reporting systems, how far are we away from what is actually really happening?
Yeah, so I have tried to understand as an epidemiologist, as a person in the public health programs, also in the public health task force of BBMP, to understand what kind of death reporting is there, and how much, by what factor are we missing. And when I look at the data, first thing is that definitely the deaths per million, if you take that as an indicator, we do not have the same burden of deaths that we are seeing in other countries. That's definitely for sure, looking at the even verifiable data. So that's really high, where you see 400 deaths per million or more. To get a reliable estimation within India, and by what factor we are undercounting, depends on the state we are in, the city we are in, and the kind of systems in place to correct and to reconcile. Why I say to reconcile? Now, we do not have an integrated system where when a person gets discharged from the private hospital, or if the person dies during the entire treatment phase, to enter that exit either from the hospital or from this world in the line list, how well this is done. If you carefully look into this in many cities, this is one of the weakest links. So therefore, you will have to reconcile the data from crematoria. You will have to reconcile the data from the civil registration system where death reporting is done. And then one has to do verbal autopsies. And combining all of this, we will get a reliable estimation of how much we have missed. Again, my educated guess is it might be a factor of 2 or 3 depending on where you are. But will it be 10 or 20 factor? I really doubt it, based on at least the data that I am aware of. But even missing by a factor of 2 is a problem. So therefore, even if it is lower burden compared to the other countries, that's still a problem which we need to fix, and not just reporting, but also medical certification of deaths that has to be strengthened. The last point on that is that why the death or the fatality proportion is lower in India or other South Asian countries is definitely a scientific question worth exploring. So people can have any hypothesis for this, but unless you prove it in terms of rigorous studies, it's very difficult. So good to begin somewhere. So I'm encouraged to see more hypotheses, but let's see.
I think we are well past time, and thank you for your patience. So I just thought we'll end with the last question here, which I think as a public health researcher is something you're best placed to tell us. What would you recommend for the general public in the beginning and middle of 2021? And we'll end with this question.
Yeah. Thank you so much. I think this is also an important question. Now, we are in hurry for a vaccine to be rolled out. We are also in hurry to erase 2020 out of our memories and our own lives in terms of the kind of adversities it has brought in our lives and in the people around. But 2021, if we say it is a new beginning, new year, our old habits, which are meeting in groups, or which we call as COVID inappropriate behavior, whatever it is, not wearing masks, closed space, within the closed space you have large congregations. All these things cannot happen through the at least next 6 months till vaccine gets rolled out fully. And even while the vaccination program is going on, we would still have to continue with this. So the new normal is the normal, and we need to continue with this. And how much ever we say it, only when we see any adversity within our families or in our neighborhood or friends, then we know we should have followed precautions. So my plea as a public health practitioner, researcher, is that let us not take things for granted. We do not have any miraculous escape from this COVID-19. It has surprised every country time and again all over the world. Let us not lose the gains that we have sustained through all the hard work of frontline workers. Thank you for this opportunity.
Thank you everybody for attending, and all the attendees who sent in some really excellent questions. And sorry for the disturbance in the beginning of the talk when I was introducing Dr. Babu. And please keep your eyes open for another WebGyan webinar, which will happen in due course as new information comes in. Good evening.